This video will cover the pathophysiology of anxiety disorders. It will primarily focus on generalized anxiety disorder, or GAD, and panic disorder, although other anxiety disorders will be covered briefly. Anxiety is an emotional state caused by the perception of real or perceived danger that threatens the security of an individual. Anxiety is an adaptive response and is typically transient in nature. When functioning as a transient adaptive response, it can be protective because it allows an individual to avoid or remove themselves from a potentially harmful situation. However, when anxiety becomes chronic, it can produce very uncomfortable and potentially debilitating arousal, both psychological and physiological. And if it becomes excessive, some individuals experience persistent, severe symptoms and possess irrational fears that significantly impair normal daily function. In summary, anxiety is the outward expression of fear, and when it is transient in nature, can be protective and adaptive, whereas when it's chronic, it can be problematic and associated with disease. There are several different anxiety disorders as defined by the Diagnostic and Statistic Manual, version 5, as well as two anxiety-related disorders that are separate and different, but yet still very similar to anxiety. And these are trauma and stress-related disorders, specifically PTSD and obsessive compulsive disorder, or OCD. The two primary anxiety disorders we will talk about today are generalized anxiety disorder, specific phobias, panic disorder, and social anxiety disorder. You can also see some other anxiety disorders listed here. As a group, anxiety disorders are the most commonly occurring psychiatric disorders. The lifetime prevalence of an anxiety disorder is about 35% of the population, meaning that about 1/3 of people will experience an anxiety disorder sometime in their life. The 1-year prevalence of anxiety disorders in adults is about 20%. Within that, various types of anxiety disorders are more or less prevalent, and that is depicted on the figure on your screen. With any anxiety disorder being on the order of 15 to 20% prevalent, the most common type of anxiety disorder is the collection of specific phobias that make up somewhere between 8 and 10% of anxiety disorders. Next comes social anxiety disorder, followed very closely by generalized anxiety disorder, and last is panic disorder. Anxiety disorders typically develop before the age of 30, but are present in individuals of all ages. In general, and as demonstrated on the schematic here, anxiety disorders are more common in women, and that is really across all different types as well. They're also more common in individuals with any sort of social dysfunction or with a family history of anxiety or depression. Anxiety is frequently comorbid with depression and substance use disorder. And realistically, a mixed anxiety-depression presentation is much more common than isolated anxiety on its own. The etiology of anxiety is thought to be a combination of pre-existing vulnerability plus life stress that leads to the expression of anxiety symptoms. The pre-existing vulnerabilities are a combination of genetic predisposition as well as parental and environmental factors that can lead to the presence of childhood adversity. Stress is made up by the combination of traumatic experiences or occupational stress or other factors in the environment and social structure of an individual's life. Over the course of development and with an existing level of vulnerability, individuals will begin to develop transient and subthreshold anxiety syndromes, like specific phobias. If those symptoms are reinforced, they can be enhanced and become more severe over time, where eventually there's the onset of threshold or clinical level anxiety disorder. Eventually, this can lead to the development of secondary complications like other comorbid disease states. It is also possible for the symptoms of anxiety to be caused by either a drug or by withdrawal of some drugs. Specifically, drugs that are CNS stimulants, like the amphetamines, etc., can cause anxiety-like symptoms. In addition, withdrawal of a CNS depressant, like an opioid or a benzodiazepine, can also precipitate symptoms of anxiety. But this anxiety should go away once the offending drug or agent is removed or completely withdrawn. Anxiety is thought to develop due to activity in multiple brain regions, including some of those shown on the screen. I will highlight a couple that seem to be most important for the development of anxiety. The amygdala is a brain region that is very commonly associated with fear and anxiety because fear processing and learned responses are coded in the amygdala. In addition, the locus coeruleus, or LC, is the area of the brain that is thought to implement the fear response. The LC is an area of the hindbrain that primarily contains noradrenergic or norepinephrine containing neurons. The hippocampus is also thought to be involved as it consolidates traumatic memories and plays a role in fear conditioning. And finally, the hypothalamus is thought to play a role given that it integrates hormone and autonomic nervous system responses to a threatening environment as sort of a central relay station for these external environmental cues. The circuitry involved in anxiety is rather complicated and is beyond the scope of our discussion at the moment. However, what is known is that there are multiple neurotransmitters that seem to play a role in the development of anxiety symptoms. These include GABA, serotonin, norepinephrine, dopamine, corticotrophin releasing factor, or CRF, and cholecystokinin. The monoamine neurotransmitters and GABA are the ones that are primarily targeted by therapeutics, and so those are the ones we will focus on momentarily. There are currently 3 prevailing theories or models for how anxiety can progress to a chronic state. The first is the noradrenergic model that involves the activity of norepinephrine. The basis for this hypothesis is that the autonomic nervous system, which releases norepinephrine both centrally and peripherally, can become hypersensitive and overreact to stimuli that can produce emotions of fear and symptoms of anxiety. This is supported by the fact that symptoms of autonomic hyperactivity are observed in individuals with anxiety disorders. The pathway thought to be involved in this model is that an external threat leads to activation of the locus coeruleus, which leads to norepinephrine release, additional autonomic nervous system stimulation, and eventual downregulation of the alpha-2 adrenergic autoreceptor, which results in excessive and overactive norepinephrine activity. This theory is also supported by the fact that many anxiolytic drugs, or drugs that reduce anxiety, decrease firing in the LC and also reduce norepinephrine release generally. The second model involves activity of the neurotransmitter GABA, which stands for gamma aminobutyric acid. This model states that due to factors like stress and other environmental pressures, there is a change to the number of GABA receptors in the brain, and specifically a decrease in the number of GABA receptors. In addition, it is hypothesized that increases in cortisol due to stress can alter the subunit expression of GABA receptors to make them less functional and less active. A decrease in GABA signaling then predisposes individuals to overactive neuronal activity. Again, this is also supported by the fact that many anxiolytic drugs target the GABA A receptor to increase GABA activity and suppress the overactive nervous system. In addition, another supporting factor to this model is that activation of the GABA A receptor inhibits signaling of other neurotransmitters like the monoamines, serotonin, norepinephrine, and dopamine. Therefore, GABA is clearly highly interconnected with other neurotransmitters in the brain, and stimulating GABA activity counteracts the symptoms of anxiety. Finally, the third model is the serotonin model. One support of this hypothesis is that when serotonin levels are decreased in individuals, this increases aggression and avoidance behavior, which are consistent with anxiety. And therefore, it is hypothesized that decreased serotonin levels could contribute to the production of anxiety symptoms. In addition, increasing serotonin through the use of therapeutics decreases norepinephrine activity in the LC, inhibits defense responses, and also decreases hormone release like corticotrophin releasing factor, or CRF. Thus, drugs that increase serotonin levels, like SSRIs, can reduce symptoms of panic and anxiety, which they do. Overall, it is likely a combination of these three models that lead to the symptoms of anxiety we can see clinically. Increased norepinephrine, decreased GABA, and decreased serotonin seem to play a role in the development of anxiety signs and symptoms. And counteracting these neurotransmitter changes can have a beneficial effect in the treatment of anxiety. All anxiety disorders are typified by the presence of anxiety symptoms as well as avoidance behavior, although the specific features of each anxiety disorder may differ slightly. In general, in order to be classified as an anxiety disorder, these symptoms must cause significant distress and impair daily function, and they cannot be secondary to a drug or disease state. Therefore, it is important to make a differential diagnosis because anxiety symptoms, especially autonomic hyperactivity like increased heart rate and breathing, can be common to many other disease states, both physiologic and psychologic. I'll focus on a few of the specific anxiety disorders here. First, let's look at generalized anxiety disorder, or GAD. This is an anxiety disorder in which the symptoms, as they are shown, must be persistent on most days for a period of at least 6 months. These include anxiety and worry about things such as work and school performance that are difficult to control, physical symptoms of tension, symptoms of autonomic arousal like hyperventilation and increased heart rate, and then the requirement for this to last at least 6 months. Next, we'll look at panic disorder. Panic disorder is characterized by spontaneous panic attacks, which are accompanied by a surge of very intense fear. As described here, recurrent episodes that are unexpected without a cue, concern or worry about having more panic attacks in the future, and this needs to persist for at least 1 month. For social anxiety disorder, this is fear about social situations that also need to persist for at least 6 months. Symptoms of social anxiety disorder can include fear, anxiety, or avoidance of social interactions, fear of negative judgment from others, and the fact that this fear is out of proportion to the actual threat. The individual may even recognize that the symptoms are excessive or unreasonable, and may also demonstrate physical symptoms like blushing, feeling the need to throw up, or need to use the restroom. Finally, we'll look at specific phobias. These are fear of a specific object or situation, which is out of proportion to the actual threat posed. And again, the individual may recognize that the symptoms are excessive. This typically persists for at least 6 months, and there are various subtypes of phobias that can include animal phobias like insects or reptiles, the natural environment like heights or storms, those that are medically related like fear of needles, situational like being on an airplane or in enclosed spaces, as well as many other phobias. Again, the important aspect of all of these features is that they are so significant that they cause distress and impair daily function. Although post traumatic stress disorder, or PTSD, and obsessive compulsive disorder, OCD, are related to anxiety, they are not exactly the same. PTSD is characterized as the occurrence of a traumatic or stressful event that is followed by symptoms of re experiencing or intrusive thoughts about the event, avoidance behavior, negative alterations in thought or mood, which is also termed numbing, and hyperarousal states. In obsessive compulsive disorder, there are intrusive obsessive thoughts and compulsive ritualistic behaviors. Again, these both share some of the features of anxiety, but also share features with other psychiatric disease states like depression and schizophrenia. What you will find is that there is some overlap in the therapeutics used to treat PTSD, OCD, and anxiety, although there are some key differences that will be covered when we get to the pharmacology and therapeutics of anxiolytic drugs. In terms of prognosis, anxiety is associated with increased presence of chronic illnesses, lower quality of life, presence of disability, other mood disorders, and other comorbid conditions such as schizophrenia, dementia, and substance use disorder. As shown in this figure, psychiatric disorders make up about 20% of disability adjusted life years lost due to disease, with the other 75% being due to somatic disease states. Of the psychiatric diseases that contribute to loss of productive life years, anxiety disorders make up the second highest, right behind unipolar depression or major depressive disorder. Fortunately, there are some good therapeutics, both pharmacologic as well as non pharmacologic, for the treatment of anxiety. Take a moment to dig a little deeper and compare and contrast generalized anxiety disorder and panic disorder. Snap a pic of the QR code to access additional information about signs and symptoms, how they are similar and how they differ between the two types of anxiety disorders.